Scapholinate instability, we'll continue with the scapholinate. It seems to work. Thierry, please, historical overview.
Yes, thank you, Christophe. My task today is to present an historical overview of scapholinated instability. Now, history is actually a science. My father was a historian. He was the chief historian for the American Air Force missile test ranges at Cape Canaveral as the sciences of rocket propulsion and missile guidance were initially being developed. He taught me that there are many kinds of history. Should let you know that for this historical presentation, I really have no financial disclosures. So after a sequence of events, we think we know how to stabilize the scaphoid to the lunate, perhaps. We can pin them together and hope the ligaments will heal. And then we try a screw, which either breaks or allows the bones to rotate about the axis of the screw and work loose. And then we try direct repair of the ligament or autograft it with ligament bone tissue. Well, none of this predictably works well for most surgeons. So we can study the evolution of scapholinate history from many perspectives, from the chronology to the anatomy to the biomechanics, treatment protocols, comorbidity, significance, and so forth. There are really too many contributors to scapholinate history to count, let alone listing them chronologically. But this list is no means exhaustive, and today's meeting, or this week's meeting, will add many other names to this inventory of contributors to scapholinate history. In the earliest scapholinate stages, these are the superstars, though, who lit the fires in sequence across that top row that started the wrist revolution beginning back in 1972. Jim Dobbins, Ron Linscheid, Julio Telesnik, really defining the anatomy of the joint, the scapholinate mechanics, and the scapholinate pathomechanics. Richard Gelberman defined the microcirculation of the ligament and of the scaphoid and the lunate, respectively. Richard Berger defined the fine points of the ligamentous anatomy. And then David Lichtman with the stage classification of instability. And then on the bottom row, these were the surgeons who introduced really disruptive techniques in surgical treatment of scapholinate instability, changing the minds and hearts of other hand surgeons. And it ranged from Kirk Watson's STT fusion to Jerry Blatt's capsulodesis for stabilization. I first developed the successful arthroscopy and arthroscopic surgery approaches to the wrist in 1985, after Chen had tried unsuccessfully accessing the wrist arthroscopically through the snuff box in 1979. So I identified the 8 major portals that we use today, introduced traction and some new instruments and the first arthroscopic surgical techniques. This really became a game changer for the wrist, as of today, most intra-articular wrist pathology can be treated arthroscopically without resorting to arthrotomy. So I showed this work to Gary Paling, and then we staged the first wrist arthroscopy course for some 40 surgeons, which launched the minimally invasive approach to the scapholinate joint in 1986. Then Will Geisler, who was one of my hand surgery fellows, later developed the popular arthroscopic classification of scapholinate ligament, succeeding David Lichtman's classification, and that was in 2013. P.C. Ho has continued to devise arthroscopic ligament autograft repairs for the scapholinate interval, both dorsal and volar. And in 2015, Christophe Mathoulin introduced the most logical and anatomic arthroscopic dorsal scapholinate ligament and capsulodesis repair. So we learn from our successes, but we also learn from our failures, and we learn from serendipity. Felix Savoy recently emphasized this teaching point. He said that every night I try to figure out how to do it better. You never really think about your successes, only the ones that didn't work. The Wright brothers failed many times before taking flight at Kitty Hawk, and penicillin was actually discovered by Alexander Fleming quite by accident in 1928 when Staphylococcus wouldn't grow on one of his moldy Petri dishes. So these are failures that were historically important for physician scientists. The significance of scapholinate history depends really on who you are. You may look at it from different perspectives. If you're a scientist like Dobbins, Linscheid, and Berger, and Galula, you look at the anatomy and the pathology and the mechanics. But if you're a surgeon treating patients, you'll look at the diagnosis and the treatment and the timing for the appropriate treatment, such as Dr. Watson, Dr. Blatt, myself, Will Geisler, Christoph Mathoulin. If you're a hand therapist like Chen or Wolf or Hincapie or Kane, you're more interested in the function and the motion and the strength reproduction. So these are the different perspectives one might take to the history depending on who they are. Or you might be a hospital administrator or an insurance administrator, in which case you're looking at scapholinate history in terms of costs for treatments, the revenue analysis, and the access to care. If you're the patient, however, most importantly, you're looking at the function of your wrist, your comfort, and the affordability of treatment. For scapholinate instability, we really must learn from our historical failures as well as our successes. And again, I leave this thought with you. For subtle joint instabilities, symptoms are based on proprioception reflexes. Just as with derangement of the knee meniscus, there's a reflexive inhibition to pivot, and with functional ankle instability, there's a reflexive inhibition to jump off the city bus. There's also, with scapholinate functional instability, a reflexive inhibition to load and rotate the wrist. And these reflexive inhibitions are conducted through the proprioceptive afferent fibers of the posterior interosseous nerve and also the volar interosseous nerve. Excuse me. And to confirm that, I refer you to the works of Elizabeth Hagert at the Karolinska Institute. So the reason we still struggle with scapholinate instability is that it is a three-dimensional problem. Historically, we've only proposed one-dimensional solutions. The Linscheid maneuver corrected the DZ in the sagittal plane. Watson and Blatt procedures addressed scaphoid flexion in the sagittal plane. Scaphoid lunate pinning and the Rassel procedure addressed the diastasis in the coronal plane. But as the scaphoid flexes, it also pronates about the oblique radioscaphocapitate ligament. Scapholunate repair and ligamentoplasty attempt to derotate the scaphoid pronation, but they really don't hold up predictably in the long run and don't address sagittal scaphoid flexion. So scapholinate instability is a three-dimensional problem, and it requires a three-dimensional solution. Repair of the DCSS by Mathoulin is promising, but will it last? And we've just heard a paper that reinforces that type of reconstruction of the DCSS. So I would submit that our history with scapholinate disorders really guides our futures. In 1890, surgeons were oblivious to the problem. Dr. Gluck, who worked here in Berlin actually, first treated end-stage arthritic slack wrists by removing the carpal bones and implanting an ivory spacer. In 2019, we are much more aware and much more inquisitive. We're intrigued about Mathoulin's DCSS repair, and as we progress toward minimally invasive surgical stabilization with reinforcing the dorsal capsulodesis. But for an historical glance into the scapholunate future, which is really the only reason scapholunate history is of importance, so that we can avoid making previous mistakes and repeat our successes, is this. By 2050, we should be even more accomplished and even closer to the truth of scapholunate instability, and we will have read about who did what and when they did it. But we're not yet there. And for the people in this room, I suggest there's really much more to do, and I'm confident that one of you will do it, ultimately adding to the history of disruptive technology for scapholunate instability. Thank you.
So now we announce Mariam Shadpour. Mariam is an incredible radiologist and
thank you. I'd like to have the next speaker, Mireia Esplugas from Institut Kaplan in Spain. Mireia is a very accomplished hand surgeon, and she specializes in the wrist, especially the scapholunate ligament. And it's a pleasure for her to be speaking on forearm pronation, the best ally in scapholunate joint stability.
Thank you very much for the presentation. And thank you for inviting me to share with you how does the forearm rotation influence the scapholunate joint kinetics. Actually, all of you know that when a scapholunate ligament deficient wrist holding wrist neutral position and a neutral forearm rotation is axially loaded, the scaphoid flexes and rotates into an intracarpal pronation. This scaphoid pronation leads to a scapholunate joint misalignment, which can be associated to a clinical scapholunate joint instability in some patients. You also know that the ECRL muscle is a powerful scapholunate joint dynamic stabilizer. When this muscle contracts, it supinates the scaphoid, and therefore it reestablishes the scapholunate joint alignment. But how does forearm rotation influence the axially loaded scapholunate joint? And does the CRL muscle stabilize the scapholunate joint in any forearm rotation? And how does the scapholunate joint react to an axial carpal traction in any forearm rotation? Those are the three questions that our carpal biomechanics investigation group in Barcelona has studied in the last 4 years, and that I'm going to resume to you. What have we done? We submitted 8 fresh scapholunate deficient wrists held in 3 different forearm rotations to an electromagnetic field, and we then registered the position of 2 sensors attached to the first carpal row bones in 3 different carpal loading conditions: axial loading, isometric ECRL muscle loading, and finally, axial traction. We then analyzed all the multiple angular data obtained using a Wilcoxon-Sand rank test to compare the scaphoid and the lunate sensors' 3D positions in the 3 forearm rotations and in each experimental situation, and P was set at 0.05. What have we found? When the scapholunate deficient carpus is axially loaded, in forearm supination, the tandem lunate trachytrum and the scaphoid rotate into opposed directions. And the scapholunate joint is completely misaligned. On the contrary, when the wrist is loaded in forearm pronation, all the first carpal row rotates as a block, and the scapholunate joint is not misaligned, although the scapholunate ligament is completely tilted. Isometric ECRL muscle loading while the forearm is in supination leads to an isolated scaphoid rotation, which brings to a maximal scapholunate joint misalignment. On the contrary, when this ECRL muscle is loaded in forearm pronation, the tandem lunate truncatum converges to the scaphoid bone, and the scapholunate joint is aligned. The axial traction of a scapholunate deficient wrist held in neutral forearm rotation carries a global first carpal row rotation as a block, and the scapholunate joint stays aligned. Instead, when the axial traction is performed in forearm supination, the scaphoid and the lunate rotate in reverse directions, and the scapholunate joint is completely misaligned. However, when the axial wrist traction is performed in forearm pronation, all the first carpal row bones rotate as a block, and the scapholunate joint remains perfectly aligned. These laboratory studies allow us to conclude that forearm pronation aligns the scapholunate joint of a scapholunate deficient wrist in any condition, either when it is axially loaded, when the scapholunate joint dynamic stabilizer ECRL muscle is loaded, and when the wrist is axially tractioned. So, when we consider a neuromuscular scapholunate joint stabilization program, the ECRL muscle should be strengthened in forearm pronation. Forearm pronation facilitates arthroscopic scapholunate ligament repair, as this forearm rotation conduces to a scaphoid and a lunate spatial convergence. Forearm pronation protects any scapholunate ligament repair, and wrist loading in forearm pronation minimally tenses any kind of scapholunate surgical repair, and this should be the position in which the patient should start loading his wrist after any surgery repair. Thank you very much for your attention.
The next speaker is Christophe Mathoulin, known to everyone. And his paper is on what is the role of the DCSS, and does that change our understanding of the scapholunate?
Okay, thank you very much. So at the beginning, we believed that the scapholunate ligament was the arch between the scaphoid and the lunate, but if you look carefully, this cadaveric preparation, you see that the aspect of this area is not exactly the same as the other one, and it's because it's not really vascularized. So we understood step by step that, in fact, there is two bones, the lunate and the scaphoid, and two ligaments, one dorsal and one volar, and something between. And in elderly people, as me, for example, probably this part is degenerative without any instability. In my practice, very often, I have some small instability, you know, like we call that a stage 2B, and the scapholunate is intact. But when we follow dorsally, we discover that there is arrangement, tears between the capsule and the dorsal part, and you see the normal aspect. And it's why everything started. The other case, you see the scapholunate is intact, we have a 2B instability, and when we arrive dorsally, we see that this area is totally torn, and look at the normal aspect here. You understood that there is a problem. So we perform anatomical work today with a big team, Jan Messina, Luc Van Overstraten, Emmanuel Camus, Abhijit, etc., etc. And we demonstrated that we obtained a systematic worsening of the scapholunate diastasis just after cutting this area. It means this bridge. And with the help of Marc Garcia-Elias, we call that the dorsal capsuloscapholunate septum. We performed 4 months of laboratory work on 17 fresh cadavers, and we demonstrated that the DCSS exists in all cases, and it was 3 arches with attached from the dorsal capsule to the dorsal scapholinate. And we published with some residents the beautiful anatomical work on this aspect. So at the end, we understood that this structure, dorsal capsuloscapholinate septum, is a bridge between the dorsal scaphotracheal ligament, which is the proximal part of the disc, and the dorsal scapholinate ligament. And it seems to be essential to the scapholinate stability, and probably its tears could be considered as the first stage of a scapholinate instability. But the most important is we understood that it's not so simple as we believe before. It's not only the DCSS, it's not only the scapholinate ligament, it is complex, volar and dorsal, with extrinsic and intrinsic ligament, and we have to take into account all these principles. And the principle of the technique I developed was just to restore the normal anatomy, and of course, without opening, because it's simplest to do that. So Max modified the technique with a very good trick, catching a large part of capsule when you have a large diastasis in order to create a constriction of the dorsal capsule, helping the reduction of the diastasis. And of course, we have to push the indication far away. Further, if you have the ligament avulsed from the scaphoid, which is the case in some cases, you can put an anchor in the area and you obtain a good stability. I would like to show you this case because for me the perfect case with this explanation. When you arrive, you see that the ligament is torn. There is a detachment between the dorsal capsule and the dorsal ligament. And when we arrive in the mid-carpal instability, we have a very large dynamic instability. It's not a static one. There is no chondral change. And in this case, we perform this repair. And look at just with the free OPDS, we obtain mechanically a reduction of the lunate, and after that we perform the dorsal suture. I was not happy with the quality of reduction, so in this case, you see, after that I'm not really happy, so I put some car wires, and after 2 months, when I return, look at the proximal part, which is unvascularized, is not repaired. Of course, it's logical. But dorsally, the aspect is very close to the normal aspect. And you remember that 2 months before, it was a completely torn area, and the patient, by himself, repaired this area. And when we perform the MRI, from the cut from the lunate to the scaphoid, we arrive to see this aspect, and it's a very good repair. And of course, the patient has very good range of motion, particularly in flexion and extension. So, during a long time, we believe that the rotary subluxation appears when you have a STT joint is not true. Of course, we understood that the DCSS changed the manner to understand and to see. Is not, of course, very the only key of the stability. And thanks to Luc and Emmanuel Camus, we understood that there is a real scapholinate ligament complex with the dorsal and volar extrinsic ligament, the dorsal and volar scapholinate ligament, and the bridge between all this system, creating a scapholinate ligament complex. And in fact, we have to understand that we have to believe in nature, which is, of course, stronger than us, and learn to it. When you put a plate on a bone, it's the bone which heals by itself. It's not the plate. It's the same for the ligament, and it is all the principle. And I love the presentation, the Terry's presentation, because he pushed us under the limit and to find a solution with stem cells, and probably it will be the next step. Thank you very much.
Thank you, Christophe. The next speaker is Dr. Nico Schmelzer-Schmidt from St. Gallen in Switzerland. We'll be speaking on arthroscopic scapholonate capsulodesis. Is it a substitute to open procedure? Nico?
So, thank you very much. This is a very interesting question, and I hope I can give you an answer, but I will refer a lot you have heard today. So, I have no disclosures. We heard about a lot of therapy options that we have for SL instabilities, and these therapy operations are very impressive, but also very challenging. And I think we all know by ourselves that we do not have yet the one operation for our patients in this problem. So wouldn't it be wonderful to have a simple solution? And that is what we saw today, was what Christophe Mathoulin developed, was SL capsulodesis. I show it to you again, because in the beginning we were thinking that the SL remnant is the necessary structure to give stability. So in the beginning we thought we are suturing the SL remnants. So this is wonderful, and in the end, perfect. So I was amazed, but how does it work? There's an SL complex, that is what we heard before. It consists of primary stabilizers, bone and ligament, and secondary stabilizers. And a main role seems to have the DCSS for stability of this complex. So here you see it again. It connects with the bone, with the capsule, and with the SL remnants. And if it is ruptures with the SL ligament together, a rotatory instability results. But if you only cut the SL ligament, it doesn't result. So that is what we saw today, the rotatory instability. In our study, you heard also today before, we thought it couldn't be the SL ligament itself, it has to be this complex, and we need most of these structures, of these strong structures, to gather them to give stability. And that was why we changed the technique in the beginning to search for the remnants. No, we didn't search anything. We diverged the needles to get most of this complex. And we had 90 patients over 3 years follow-up. I only used 6 weeks of forearm cast, and we classified to Geisler and to EWAS. Most of the patients had an EWAS 3B and C and 4 lesion. And what we saw was that there was an improvement for the patients of EWAS 3 and 4 in the SL gap, but also an improvement for the force and for the range of motion. But we had failures in EWAS 5. So we cannot recommend this technique in EWAS 5 lesions. Here you see again the range of motion and the grip strength. But I'm very convinced of this technique because I see the patients, and the patients have a great range of motion. They have up to no scars, and they are very satisfied. So for me, it is a substitute for open procedures in EWAS 3 and 4 lesions. This technique can achieve more stability in dynamic SL instabilities, and we have to think it new. It is an SL complex, not the SL ligament itself, which gives us stability. The key of this therapy, in my view, is to get most of the dorsal strong ligaments without field damage. So all other options stay open, that is sure, and you live and learn, and you have the choice to see more and to discover more. Thank you so much.
Okay, thank you. We have 7 minutes for discussion, and the question is, do we still need to open the wrist? It's a very interesting question. So I would like to ask if anybody has any question to the different authors. If yes, please stand up and go directly to the microphone to ask your question. Thierry, you're our mentor for the treatment of scapholinate ligament. When we can ask this question, do you think it's still necessary to open the wrist now?
It might be, yes. I think it's necessary for some people who don't have the arthroscopic reparative skills to accomplish some of these more complex reparative reconstructions arthroscopically. But one of the significant things that I learned today was from Miriam Shabapapour, the imaging qualities that will allow us to get a preoperative diagnosis that really isolates all of the extrinsic stabilizers is remarkable. And if she could only be cloned into each of our diagnostic armamentarium, that would be wonderful. Second, it's erroneous, I think, for us to believe that all of the injuries that we see in any given patient are the result of a single injuring event. We don't know the history of progressive injuries in anyone, and there may be complex associated comorbidities in any given wrist that we don't really address if we try to attribute it at all to the same injury.
Could we have the gentleman?
Yes, to the radiologist, thank you very much for this very insightful talk. Could you point out from your point of view as a radiologist, where do you see the dorsal SL ligament ganglia cysts with respect to the DCSS? Where exactly is the ganglia cyst in the dorsal SL ligament, and where exactly is the DCSS? Is there some interconnection? What is your point of view?
It's very difficult to identify the DCSS when it's normal, because the structures are very thin and small, and even with our 0.4 millimeter slices, it's difficult to identify it and to see where it stops and where it starts. But what is quite easy to see is when you have lesions. So when you have a distension, even of a few millimeters, on the 3D sequence, and especially the DES sequence, much better than the 3D FATSAT, where there are many publications, but the quality of the 3D FATSAT is much lower, because the big difference between the DES sequence, most of the images you have seen, and the other PD FATSAT sequence is that the first one is a fast sequence. So that means that you can get much better resolution of your images. You have a TR of 30 milliseconds, while to get the same with a 3D PD FATSAT, you need a TR of 1,000. That means that we need 1 hour or more to get the same resolution. So if you do those 3D DES sequences, you really can see where the ligament stops, or where at least the cystic distension stops, and where is the dorsal band and the dorsal intercarpal ligament. Only on those thin sequences. Did I answer?
That we all dream to have Mariam as a radiologist.
Absolutely.
Sure. Mark, question?
Mark Garcia from Barcelona, Spain. I think that the answer to the, do we need to open the joint? I think always they will have a more complex injuries discovered, that we will analyze those, and we'll see that there is a combination of intrinsic and extrinsic ligaments. And extrinsic ligaments arthroscopically are very difficult to solve than the intrinsic ligaments. So the answer is always we will need to open some of those cases. Fortunately, the cases that we were opening them 10 years ago, now they did not, they don't need to be opened now. But sooner or later, as long as we understand that there are many more injuries around, we'll have to keep an eye on opening that joint. And that's why I think that it's very sensitive, not only that EWAS has changed the E to the I, but also the A probably should go, because that means that we need to keep an eye, that we need to use arthroscopy and also open procedures to solve all the problems. So arthroscopy is a tool, and we should keep going in both techniques.
Thank you, Mark. And you know, in fact, if we, of course, we need to sometimes to open the wrist for some indication, it's sure. But it's sure also that the open surgery decreases a lot, step by step. But the take-home message maybe will be the very important thing is we have to make the diagnosis early. That is the most important. And this is why, as surgeon, we have to believe in your thumb, in the comparative dynamic X-ray and MRI. And if we have any doubt, it's nothing to perform a wrist arthroscopy even white, because it's less dangerous to leave, or perform a wrist arthroscopy for nothing than to leave a scapholinate extend to a static lesion. So probably the most important thing is to make the diagnosis earliest possible. So one question, the last one, please.
Okay. In dorsal capsule disease, do we need the K-wire transfixation? And if yes, in what cases?
For me?
Yes.
Yeah,
yes.
Thank you very much. In my practice at the beginning, I systematically placed K-wires because Thierry explained us that we have to reduce the scapholinate and to put some K-wires. So at the beginning, it was like that. But step by step, I discovered that, in fact, it's not necessary in the majority of cases. And now it's less than 10% of cases. So I perform the suture, and I see, you know, when I pull down the suture, I see if there is an automatic reduction. If I see that, I don't put any K-wires. If the reduction is not satisfactory, I do the suture, I see, and when I check that the reduction is not perfect, I reduce, and I put some K-wires.
And before you go, permit me to say this, now that we all understand the DCSS and its significance, rethink the way you treat dorsal ganglia arthroscopically.
Thank you very much, and thank you, Terry, to be there. Thank you, Mark, to be there too.